Hello, and thanks for joining me today as part of the 2020 Brigham Harvard Computational Data Science Symposium. I'm excited to be speaking to you today from Nashville, Tennessee, where I'm a neurosurgeon at Vanderbilt University Medical Center. My clinical specialty is skull-base and brain tumor surgery, and my research interests lie in part with predictive analytics to help define and improve outcomes for patients with those disorders. My approach to data science is as a clinician first, as none of my formal education was in this space. Rather, I was first a traditional healthcare outcomes researcher. However, I became exposed to the concepts of machine learning and AI some years ago, and I recognized their potential to provide dramatically better tools to do the work that I was interested in. So I've done my best to teach myself some of these methods and also engage with collaborators who've helped me shift the direction of my lab into this space. So when we get to the Q&A later, hopefully I'll be able to share some of the lessons that I've learned with any of the clinicians and biologists that might be tuning in today. In this brief talk today, I'm going to provide an overview of how natural language processing is being used in the field of neurologic disease. NLP is one of my favorite applications of machine learning for several reasons that I'll share as we go on. First, I have no financial disclosures to make today. I have one fiduciary commitment as a member of the board of the Congress of Neurological Surgeons. So let's start by defining NLP. In brief, this is a branch of artificial intelligence whose objective is to analyze human language in a way that allows us to make sense of that data in a manner that's useful, which often practically means predictive. Language broadly includes the spoken word as well as written text or symbols used by humans to communicate with each other. This method draws from a fairly disparate set of traditional academic fields, which is one of the things I find most interesting about it. NLP as a method has really come into its own only in the last decade, in part because of the computational power required to handle large language data sets. It's very large. And the development of the graphical processing unit has really made this possible. To understand this work, it's important to take a moment to think about the concept of sublanguages. The audience listening to this talk all likely speak English, I hope, because otherwise this is very confusing. And many of us also speak other languages as well. But let's take English for a minute. Each of us is fluent to varying degrees in multiple sublanguages of English. For example, I'm pretty fluent in medical English. If I see the initials CTH, I know that means a non-contrasted computed tomography scan of the human head. On the other hand, I'm only passable in social media English, like you see here. Social media represents a completely different sublanguage, which is still young and evolving quite rapidly. There are, of course, all sorts of novel abbreviations that became common as humans started to communicate electronically by text, things like OMG or LOL, that are essentially words of their own now. There are also now symbols, emojis, for example, that communicate multiple ideas with significant meaning. As an example, I'm showing you a cute Instagram post here. You can imagine that an NLP algorithm built to analyze social media would need to know what text over there in the comments to discard as irrelevant and what meaning to ascribe to those hearts and flags that you see over there on the right. That challenge is illustrated here pretty nicely. On this post, I think most of us would understand that the blue hearts mean that the reader likes these American-themed sprinkles. Blue hearts can have a completely different meaning, however. In a large study seeking to identify indicators of suicidality from social media posts, blue hearts were actually the emoji most strongly associated with an imminent suicide attempt. So we might need to be checking on the ice cream lover, but more likely, context is important here, and NLP algorithms analyzing emojis or any other form of human communication have to be trained to identify and sort those contexts if they're going to be valuable. So let's move on to the uses of NLP in medicine and in neurologic medicine in particular. We're going to look at a few of the broad categories of use that I think are important to recognize. First, and perhaps most obviously, NLP has a role in providing predictions. I've given you the reference here for a great methodological paper. This group studied the pattern through which children with seizures were identified as surgical candidates and subsequently referred for surgery. This is an important clinical issue because we know that early surgery in appropriate epileptic patients has significantly improved long-term outcomes in all kinds of things, like seizure control, neurocognitive development, academic progress, and even disability as an adult. So these authors looked at a nice narrow problem. Could they create an NLP algorithm to evaluate clinical data in such a way as to predict which children were surgical candidates? Their gold standard was a group of expert neurologists seeing these patients. What they found was that indeed their algorithm was as good as the neurologists at predicting who could be considered for surgery. Where it really shined, though, was in timing. The algorithm could identify those surgical candidates significantly earlier in their disease course than the neurologists. That could mean that use of this algorithm could allow early referrals for surgery, prevent losing patients who are lost to follow-up. And we know that that would improve long-term outcomes in these children. This is a nice example of a place where AI can work as decision support for clinicians, and anyone interested in methodology would be smart to study this. Sticking with epilepsy for a moment, I wanted to highlight another interesting manuscript. This group built an algorithm based on NLP, which extracted text from the medical record for analysis, which detected patients who were at risk for a clinical phenomenon called sudden unexpected death in epilepsy. This is obviously a much studied devastating complication of epilepsy, and many efforts have gone into improving our ability to predict it, but none have necessarily been as successful as this NLP algorithm. There's an obvious potential here to develop a point of care intervention to allow these patients to be detected based on the records in their medical record, and allow clinicians to activate some sort of red flag and identify them for an intervention before they undergo this devastating complication. Beyond that, reverse engineering these results from NLP analysis may help clinicians learn what actually causes this event, as we still don't know. As you can see, the cleanest uses of NLP in healthcare at the moment often involve predicting important, discrete clinical phenomena. Quality improvement efforts are a natural fit for this type of work. This is an example from a Harvard orthopedic spine group. Here, the challenge they chose to address was not the detection of a negative outcome, postoperative wound infection, since almost by definition, those will be readily identifiable by the clinicians. Rather, they sought to automate that detection process to ensure that this important quality measure was accurately reported to the physician's practice and hospital. This type of system improves the efficiency of quality reporting and sets the stage for point of care applications or dashboards that will allow physicians to access their complication rates in real time with minimal manpower used to extract and process that data. So I think I've saved the best for last. I'm personally most excited about the impact NLP may have on our fundamental understanding of human disease. We know that NLP allows us to extract and use data within the health record in novel ways that allow us to construct richer clinical phenotypes than conventional data collection alone. As we make those clinical phenotypes more detailed and easier to identify and group, we can then merge that more accurate clinical data with genetic data to form novel associations. Those connections are the critical basis of our understanding of both heritable disease and acquired diseases like cancer, and they'll ultimately drive development of therapeutic interventions. So now that I've gotten you all excited, I obviously need to apply some caveats. One of those is the looming issues of medical documentation. It's well known that changes to EHR platforms, reimbursement, and medical legal concerns have driven us to a place where notes are increasingly templated. Voluminous auto-imported data in progress notes, a trend toward cut and paste, and the use of medical scribes will all change the way NLP has to be adapted to the health record over time. In other words, what works today may very well not work very well or very predictably in 5 years. As I mentioned a few minutes ago, attention to sublanguages must be paid and can limit the extent in which a given NLP algorithm can be generalized, even at the same time point, across regions or institutions. Finally, there's innate linguistic features that can mean that doing this work in certain languages or dialects can be particularly challenging. I think it's worth taking a final moment to discuss what I think is a very useful cautionary tale. IBM Watson burst into fame when it beat the best human Jeopardy players handily, bringing AI into the public view. Watson Oncology, however, was not nearly as successful. This technology attempted to use NLP as well as other machine learning techniques to improve treatment recommendations for cancer patients. However, there were many notable stumbling blocks. For example, while the algorithm was in early use, a basket trial was published. This is a clinical trial that looked at 55 patients with various cancers, all with the same driver mutation. And this trial demonstrated that a particular drug had a profound effect on patients with that mutation. Oncologists immediately determined that any patient with lung cancer, for example, should be tested for that mutation because of this possible treatment. However, Watson could not be tweaked into producing that recommendation because only 4 out of 55 patients in the trial had lung cancer, and that didn't meet preconceived limits of power programmed into the system. Watson generally was found to recommend well-established treatments oncologists already knew about, and it struggled to incorporate breaking news into clinical recommendations. It also proved incapable of organizing temporally confusing information. For example, updates to a diagnosis that were added into the record in a delayed manner produced a seemingly non-linear timeline of disease that it could not understand. IBM has not yet produced a marketable product from this huge investment, though it seems obvious that the lessons learned through this failure will be useful contributions to future, probably smaller scale efforts. So with that, I will close today, other than to welcome all of you to visit us at Vanderbilt in Nashville whenever you are able to travel again. And I look forward to getting to meet many of you in person at a similar event next year.